Start.
Good evening, everybody. I welcome you once again to the monthly meet of the Trivandrum Neuroclub. We are very excited today because we have two very esteemed faculty from Aster Medcity, Kochi. Dr. Durgapoorna from the Department of Radiation Oncology and Dr. Vijay Jayakrishnan from Interventional Neuroradiology at Aster. And we also have a very illustrious panel of moderators and discussants. Dr.Rajeev, I'm very happy to welcome from the Regional Cancer Center, Trivandrum, Professor Easwer, and Dr.Ajith Cherian from Sri Chitra Institute, and also Dr.Jyothish, Dr. Jayadevan, and Dr. Manish Yadav from KIMS. Let us immediately get into the task because it's been a tough day for all of us. Some of us would have had a very memorable day, while some of us probably it wouldn't have been that exciting. But I'm sure that the experience of this webinar will totally give us a new perspective of things for the day today. And let me get started immediately by introducing and inviting Dr. Durgapoorna, who would be speaking to us on radiation therapy for intracranial vascular lesions, the why and the how. Usually, most of us associate radiation oncologists with malignancies. So it's very fascinating to hear the treatment of a benign lesion, which could probably have a malignant clinical course from an expert in malignant diseases, Dr. Durgapoorna, speaking to us on intracranial vascular lesions. Welcome, madam, and thank you.
Good evening, and thank you for giving me this opportunity. Please do forgive the sequence of my talk because I said I'll talk about the why and the how. Now it's probably going to be the reverse, the how and the why. That is one. And secondly, people say that all is fair in war, love, and GBM, but probably all is not fair when you're treating benign disorders, and especially with radiation therapy, like you rightly mentioned. I think I'll just start off with the presentation now, if that's okay. So I'll be talking about radiation therapy for intracranial vascular lesions, the why and the how, or in reverse, the how and the why. I'll be talking first about radiation per se, what exactly it is, how it is being used. It could be a little boring for Rajiv, but he'll have to bear with me about the mechanism of action of radiation, the different techniques that are used, the SOPs used in various departments, the types of vascular lesions where there is an evidence to use radiation therapy and where there is no evidence to use radiation therapy, and a few clinical case scenarios if there is time. So radiation therapy, I hope everybody remembers their 12th standard physics. This bearded gentleman showed he passed electrons through a high metal tube, and those electrons hit a high energy metal tungsten target and produced some rays. He didn't know what to call those rays. So because he was a mathematician, he called it X-rays. And that is how X-rays came into clinical practice. And very shortly within that, before the turn of the century, it was being used widely for all kinds of malignant and benign disorders for diagnostic and therapeutic purposes. And there was a host of evidence to use radiation in clinical practice. The first case report of a cure with radiation therapy was published by 1898, very shortly. So how does radiation act? There is not much idea about how it acts. We just know that the body is made of water, and the electron hitting water causes hydrolyze the water into H plus and OH minus, and a photon hitting on an electron in the outer orbital can cause the release of electron, causing H plus and OH minus, causing the electron can hit a DNA directly. So it can cause either a single strand DNA break or a double strand DNA break, and this causes radiation damage. The biological effects of radiation can happen within fraction of seconds and might continue for years, decades, and generations. So at each moment, something could happen that could trigger the next event that causes the next event down in the cascade. The molecular basis, there are all kinds of theories, addition molecules, induction of apoptosis. The more complicated the explanation, the more likely that nobody really knows what's happening. So radiation acts is all we know. And I sometimes joke with our patients that it's something like God. You don't see it, you don't hear it, but you definitely probably can see the effects. And conventional radiation therapy protocols deliver somewhere around 50 to 60 gray in 30 fractions, 1.8 to 2 gray per fraction, 5 fractions a week. And 1 gray is defined as 1 joule per kilogram and corresponds to the rise in temperature of 100 ml water by 0.0024 degrees Celsius. That is how small the amount of energy is that we are talking about. 100 ml water by 0.0024 degrees Celsius. And the basic principle of radiation therapy in the clinic that we use daily is based on the 5 hours of radiobiology. I'm quickly going through this. I'll try not to confuse people too much, but I think some background is needed before we try to build up on what exactly this is. This is still in the realm of science fiction. Nobody has proved it, but it seems to work for the last few generations, so probably it works. So the 5 hours of radiobiology that people talk about is repair of sublethal damage. The single-stranded DNA breaks can be repaired, that double-stranded breaks cannot be repaired. So this repair happens. So when you give small packets of radiation per day, after each radiation, there is some repair of sublethal damage so that the cells move into the reassortment into the sensitive phases of the cell cycle, the G2 and M phase. There is some reoxygenation so that radiation can act better. There is repopulation of the surviving cells, and there is also an increase in the radiosensitivity. This has been held as a kind of dictum and rule of clinical radiation oncology for a very long time. And that is how you explain how radiation acts, radiation acts with conventional radiation therapy. And conventional radiation therapy could be with 3D conformal radiation, IMRT intensity modulated radiotherapy, the various kinds of stereotactic radiotherapies, and also proton beam therapy. I will try to give a hint of how each technique works. The simplest method of treating anything in the brain is with a parallel opposed fields. You give one field from one side, you send the other field from the other side, and when you're giving 45 gray, somewhere around 47, 48 gray might come on the medial temporal lobes, but you still manage to cover the target with what you're prescribing. You move on a little bit and you get 3D conformal radiation therapy. You give radiation from two or three different directions. You have a beam coming from 3 different directions that converge at the center. You have shaping of the beams to the target so that some of the radiation that goes outside where you want to treat, the normal tissue, gets blocked using what are known as multi-leaf collimators in the modern linear accelerators. You also have micro multi-leaf collimators. If multi-leaf collimators were 1 centimeter, micro is probably 2.5 to 3 centimeters or even less. So you can shape the beam that goes through and try to reduce the dose of radiation that goes to the normal tissues. Extension of this is intensity modulated radiotherapy. You have say 5 or 7 or 8 beams that come from multiple different directions. You can kind of dose paint. You give higher dose to the tumor, but nearer the optic apparatus and all that, you can try to give a little lesser dose. And this is based on the principle of beamlets. That is, you have multiple tiny beams within the IMRT beam, which gives a different energy at different times. I'll not even go into it, sorry. So, and then you come to what is now the latest fad, which is protons. Protons use high linear energy transfer of radiations, and there is something known as a Bragg peak. That is, after depositing all the dose, it just comes to a stop. And that is how you can get this kind of distributions in protons. Like, this is kind of same plan of the same tumor with with photons and with protons. With normal radiation therapy, you get beams coming from different directions. You get almost the same kind of dose with protons as well. But if you notice, you cannot see any of the exit dose. The beam energy comes in, gets deposited on the target, and does not, there is no deposition outside it. It's all absorbed within there. Like, for example, if you have very low dose of radiation coming outside, in the spine field of a craniospinal radiation therapy, there is next to nil with protons. And then the stereotactic radiation therapies, you have multiple beams coming from multiple different directions that converge on the tumor, and you try to get conformal dose distributions. The idea is to give maximum dose to the target, minimum dose to the surrounding normal structures. And when you talk about stereotactic radiosurgery, you cannot go further without talking about this gentleman who first started the concept in 1951, introduced the gamma knife in somewhere around 1968 to 70, and conceptualized what is still the basis of stereotactic radiosurgery. It is based on stereotaxis. That is, you try to define the tumor within a set of coordinates within the patient. You give X, Y, and Z axis within the patient's skull, and you try to define the tumor inside of those. The location of the tumor is precisely defined within the X, Y, Z axis. It is based on image guidance. You have to have a CT scan or an MRI or at least a DSA or a skull X-ray before you deliver radiation therapy. You give beams that come from multiple different directions. So you have 100 beams that come from different directions. Each will be giving 1 ray each, and you can give 100 ray to the tumor. This is just an example. It is much more than 100 in real practice. So you give a very high dose of radiation therapy to a small, sharply defined target, and precision is the backbone of whatever stereotactic radiosurgery is all about. There are many different modalities of delivering SRS. It could be with a gamma knife, a LINAC, a cyber knife, or a proton. But the basic idea and concept is still the same. So all these have developed parallelly. Again, this is just for historic reference and of interest, but nothing much else. After this thing of the discovery of X-rays, even probably within the next 10, 20 years, there was some interest in trying to put the skull within a framework and try to define it with respect to those coordinates, and which has led to the revolution radiosurgery that we are seeing now. So for conventional radiosurgery, what normally happens during the procedures, you first attach a stereotactic frame to the patient's head. In modern radiosurgery, when you do not have a stereotactic invasive frame, what you do is, you use what is known as, you've got a sturdy fiberglass couch attachment that is fixed to the LINAC couch. You make a nice tight mask with the patient lying down. You have maybe a double layer or a triple layer mask that makes sure the patient's head does not move. And you can probably use arrays to make sure that the patient's head is fixed and it is monitored. As compared to what we used to do earlier, we used to have invasive frames. We used to define the patient's tumor within the N frame and do the treatment with the frame in place. The frame was being fixed to the LINAC, and that used to define where you deliver radiation therapy. Now, after fixing the frame, you image with the reference frame in place. You define where the isocenter, that is the center of the tumor is. You define where the center of the tumor is with respect to the N frame or whatever frame you have used. You plan radiation therapy that comes from multiple different directions. Maximum dose to the tumor, minimal dose to surrounding normal structures. You do a quality assurance run to make sure whatever you're planning is actually what is being treated. And then you probably deliver the actual treatment. So the target localization was correlated with respect to the coordinates, and which was reference to the machine isocenter. So you place the patient on the machine and you move the isocenter of the machine to wherever you have defined as the center of the tumor. That was how conventional radiosurgery used to work. You take CT images, which was required for physics planning for most linear accelerators. For gamma knife, it is still the MRI. You may or may not fuse the CT and the MRI, define the targets, and then you place the beams. In gamma knife, you use shots of different sizes, which are superimposed on the same isocenter. In LINAC-based radiosurgery, you can either give multiple beams that come from multiple different directions. You can use multiple arcs that converge from multiple different directions, or you can even use non-isocentric beams. That is, each part of the tumor is treated by, say, 10 beams. And these 10 beams do not treat the rest of the tumor. So over treating each part little by little, you try to cover the entire tumor. So that is what CyberKnife is about. For beam modifications, you can use either collimator helmets in Gamma Knife, or you can use cone-based. These are all to shape the beams. Cone-based, or like I showed earlier, MLC-based, either micro MLCs or even high definition MLCs. But either way, you're just using multi-leaf collimators. Smaller leaf collimator, that's all. Multi-leaf doesn't mean much. Duration of treatment could be even a few hours in the older Gamma Knives as compared to triple F therapy, where it gets over in 3 to 4 minutes, or even flash radiotherapy, which is supposed to be the next future, where it gets over in seconds. Imaging was resisted. The imaging, I'm talking about imaging before treating the patient. How do you make sure that you are treating what you wanted to treat? In Gamma Knife, they thought that it was so precise that it really didn't matter. But now there is some amount of interest in using the imaging in Gamma Knife also with the new icon. In linear accelerators, it was essential because you were using it for fractionation. You could use either orthogonal X-rays, which are being used in our Exatrack or even in the CyberKnife, or you could use a cone beam CT or CT on the machine and try to match it with the tumor and give couch corrections within 0.7 millimeters. So that is in the range of millimeters, and that is the kind of accuracy you can get in a linear accelerator as compared to probably 0 errors in a Gamma Knife. So again, if you think the tumor might move, you have all kinds of tracking devices to see if the tumor is actually moving or not. There are all kinds of image resolution improvement and quality assurance changes that have come in. So basically, there has been a host of options that you can use and try to decide how you want to deliver stereotactic radiosurgery. Anyway, now coming to the types of vascular malformations, I think I'll probably stick my talk more to AVM than anything else. Probably a little bit of mention about cavernous malformations and maybe dural fistulas, but nothing much else. I will not be talking even about telangiectasias or venous malformations. AVMs are the most common vascular malformations of the brain, with an incidence of approximately 10 per 100,000 population. So it is believed to be composed of feeding arteries, a nidus, and a draining vein. There is no capillary bed, and so there is a lot of vascular shunting within the arteriovenous malformation. A nidus could be diffuse or a compact nidus, depending on the pattern that is seen on the angiogram. The most common presentation is with the hemorrhage, and the most common cause of non-traumatic hemorrhage in a patient less than 35 years is probably anemia. Also, it can present with a lot of other findings. There is a 2 to 4% annual risk of rupture. And why we are worried about this is because of the younger age group that it is seen in. The chances of hemorrhage increases if there was a prior hemorrhage, if there is a single draining vein or a deep venous drainage, especially if the location is in the posterior fossa or periventricular region, or if there is venous stenosis or increased pressure within the nidus and all those things. So all these things kind of help you decide whether you really need to treat these things or not. It is more of a philosophical question nowadays than anything else. There is a Spetzler-Martin grading, of course, along with some supplementary data like the age, if there is a bleeding, if the nidus is compact enough or not. Treatment options could be any of the above, but this I've taken from the thing from Pittsburgh, from the University of Pittsburgh, which have got the largest data on use of radiosurgery for any indication. So because they're so used to it, most of their recommendations for most of the things are for radiosurgery, radiosurgery, and radiosurgery. If there's a small nidus in a lobar location, if it is resectable, resect. If there is a residual nidus, try if you can resect again. Otherwise, follow up with radiosurgery. If you have a small nidus in a deep location, radiosurgery. If there is a residual, you give a second radiosurgery. So on and so forth. Now, evidence. Well, The first AVM patient was treated in August 1987. Again, that's Pittsburgh. And they recently no, maybe some 15 years back, in 2007, they published their first 1,000 patients with AVM that were treated with stereotactic radiosurgery. So there is huge experience, basically, because once radiosurgery was started, after the functional indications, the most common reasons for treating with radiosurgery was pituitary, because you could see the cella and target the cella on X-rays, or AVMs, because you could see the tumor blush on the target blush on the PSAs. This was before computers and three-dimensional imaging came in. So there is a lot of experience, and it has been used since 1972 or something similar. Anyway, again, in pediatrics, there is the 30-year Pittsburgh experience that was again from Pittsburgh, published recently, which showed that there was not too much of, this was everything, not just radiosurgery alone, but there was no difference much in the outcome. Recent data, again, you've got huge numbers of patients, data published from all around, even from India, that shows that there is a reasonable obliteration rate with radiosurgery, somewhere around 60 to 80%. Obliteration, of course, depends on the volume of the target, whether the AVM is large or small, the number of isocenters that are being used. Obviously, if it is larger, you will use a more number of isocenters, especially in gamma knife. If the higher the marginal doses that were given, the higher the chance of obliteration. The smaller the score, I've not even covered the score. It's something you can always Google and find out. We never tried to memorize it ever. The lower the spread margin grade, the better was obliteration. The younger the age, the better was obliteration. But history of embolization was probably the thing against obliteration. So how do you choose what dose to give? Again, this was published by the Pittsburgh group. Most of the, the series with large numbers of patients was from the Pittsburgh group. And anyway, they said that somewhere beyond 25 gray, there was no difference. So you have to give somewhere around 20 to 25 gray, whatever you are comfortable with. Our practice has always been to give much lesser doses. We've been giving 15 gray, 16 gray, and seeing good obliteration. We've been in the process of publishing it for a very long time now. We will someday publish it, hopefully. So the marginal dose seemed to be somewhere around, beyond 25 gray, there was no difference in the obliteration. Whereas between 14 to 16 gray is probably where it starts getting in. Again, provided you do not have post-radiosurgery injury, either radiation necrosis or whatever else. And for this, it's always prudent to look at this thing from 12 gray and the 10 gray volume, the volume of the brain that gets 10 gray and 12 gray when you prescribe, say, 20 gray or 25 gray, and where you can get symptomatic radiation necrosis. I don't think any discussion would be complete without mentioning this trial. It was an unblinded randomized trial. A lot of criticism against it, but anyway, the basic this thing take home from the trial, from the study, was that there was, in an unbled AVM, there is probably not much benefit with any intervention. There are strong believers, there are strong non-believers. Again, I'm not getting into it. So what do you do when you have a large AVM? A large AVM that is bled. Large AVM that is not bled, Aruba says you shouldn't do anything. Okay. You can either do a volume stage or a dose stage SRS. You can either give hypofractionated radiation therapy or fractionated stereotactic radiosurgery. I think I'll come to each of these, or we can even talk now. Volume stage SRS is you treat 1/2 of the target on day 1. Sorry. This was a patient we treated. He had it was an 8-year-old child with a large AVM. We treated the first target, the one away from the stem, with 13 gray, a little lesser than our usual dose, in October. We treated the second half, 6 to 8 months later, another 13 gray. And the basic idea is that you obliterate one half, the half with the most amount, the highest probably vascularity on day 1. You hope your radiosurgery produces enough effect to, if not shrink the tumor, at least decrease the risk of bleeding. And then you treat the other half and you try to match both these things. To a radiation oncologist, it sounds one of the most stupidest thing to do, because one, you don't know where there is going to be radiation necrosis, where these two are going to overlap. You don't know, you're giving a much higher integral dose to somebody who might live for a long time. And you might alter the flow mechanism and all those things and actually end up causing more bleed. But there seems to be some evidence. I will again come to that a little later. Hypofractionated radiation therapy is the other extreme. So what you do is, instead of giving, say, 25 gray, you give 30 gray in 5 fractions or something like that. So that instead of treating today and then 6 months down the line to 2 halves of that particular target, you treat the whole thing to a much lesser dose. If it comes down, you can follow up with a proper normal radiosurgery a little bit. Another option would be to embolize. If you can actually get Vijay sir to embolus just one branch and take off one wedge of the AVM, then you treat the remaining 8 portions with radiosurgery. Provided he doesn't do a, it is not a centripetal thing and it is actually one nice chunk removed. Or if you cannot do anything else, you give conventional radiation therapy. There is evidence even for that of giving 45 to 50 gray Monday to Friday, Saturday, Sunday off, like you treat a normal pituitary or a meningioma. And then there'll be some obliteration, maybe around 50% or something less. But still better than nothing. So when would you consider repeat SRS? If there is a nidus, even 3 years after the initial SRS, provided the nidus is shrunk, you can probably give a much higher dose. Only problem is that radiation effects could be almost twice as compared to just a single SRS. But then that is a risk probably you will have to take. Cavernous. Okay, because of the much lower pressure, the bleeding is much less and mostly present with seizures. I've treated only one case because most of the cavernomas are taken out by the neurosurgeons. Here or in my previous institute, the basic idea is because of the architecture, you have these big blobs of tissue which cannot be even seen on an angio. So how do you target it? And if you have an T2 MRI, you can just about treat those patients, but then very difficult to even compared to the obliteration rates that we saw, the impressive obliteration rates that we saw with AVM, you cannot even demonstrate it on any imaging. So if the patient hasn't bled, it seems to have worked. That's all you can say. Again, people who are enthusiastic for radiosurgery say that because if the risk of bleeding increases with each prior bleed, maybe if you give SRS, you can decrease it to 1% per year. Anyway, it is not routinely recommended, although there is actually a guideline for stereotactic radiosurgery in cavernous malformations, again from the Pittsburgh group. Dural arteriovenous fistulas, I have not even treated one, so I have no idea how to treat. Pittsburgh says RT followed by endovascular, the thing is a way to do it, probably. Let me wrap up the talk with a discussion on the late effects of radiation, especially when you treat something like an AVM. That is something you cannot not talk about. People have been talking about new deficits that might come in, new neurological deficits that might come in, maybe around 5%. Seizures are probably less than what you would expect with the surgery. Imaging abnormalities may be seen in almost every other patient. You will see some kind of, if radiation has gone somewhere around that area, you might see some T2 abnormality. Cyst formations have been described. The nidus dries up, and in the place of that, you get a cyst a few years earlier, a few years later. As long as it doesn't bleed, I wouldn't be even bothered about it. This is what is worrying. You're treating a young patient who might have a life expectancy, who might outlive any of us here, and you might end up giving them meningiomas, glioblastomas, and all that. And that is a risk that has to be discussed with every single patient. Recurrence of AVM cognitive deficits have all been described, but again, nobody really has seen or heard of all of that. Basically, probably because you're treating a very high dose to very sharply defined target. If we have time, can I just show 2 cases quickly?
Sure, madam. No problem. Please go ahead.
Yeah, thank you. Last 5 minutes. Okay. This is just to show you how, I don't know what to say, but how exciting it was. This was a patient we treated with 14 gray in 2007. And when we did a CT angio at 2 years, there was nothing there. And that was how it was really very gratifying to see the results at that time. Compared to that, let me show you the case of a 47-year-old lady who presented with, see, this is after some time. We had actually gotten some experience treating with radiosurgery, and we thought we were big guys. Presented with headache, vomiting, all that usual stuff. There was an intracranial bleed. And there was a Spitzer Martin grade 5, nidus of size 6 into 5 centimeter, which was quite close to the stem. Initially, a partial onyx embolization was done, and then we gave 3D conformal radiation therapy, completed in October. So, multiple beams coming from multiple directions given to the tumor with normally fractionated radiation therapy, as we would have done for a pituitary. Then she presented with 3 years post-embolization. She presented with hydrocephalus, bleed, this, that. She had some 5 admissions during those 2 years. But however, she did not have any further bleed after December 2015. And this is why. Because we gave stereotactic, we re-radiated. We gave volume stage SRS. We treated nidus 1, the bigger one, 8.6 cc with 14 gray, the smaller one, 15 gray. And then when we did the DSA 3 years after volume stage SRS, this was what we saw. Well, I usually end my talks with this slide, but I think after talking about volume stage radiosurgery, this is probably more appropriate. Thank you.
Thank you very much, madam, for that very fascinating talk. I'll just pick up one line from Dr. Durga's talk, which said that radiotherapy is like God. So, which it does its work, but you can't see it doing its work. So probably the extension of that would be that radiotherapists are the high priests or the pujaris who introduce us to God. So to keep the discussion going, may I invite the other high priest who is on our panel today, Dr. Rajeev from RCC. We are very honored to have you. Could you, sir, please start a discussion?
Yeah, first of all, let me congratulate Durga for a wonderful presentation. She has actually covered a lot within a short time period. It's very difficult, starting with the basics of radiation to such an extent where how would you go and approach to a patient with AVM. So I have nothing much more to add as the technique is concerned. But I would say rather clear, really it's a teamwork. Probably Durga also knows that it's really a teamwork where the attention from an interventional radiologist and neuroradiologist, radiation oncologist, all comes into a real play. And that is the most important part of it. And the other part is for a radiation oncologist, it's very important to get a proper delineation of the nidus. Actually, we don't look into the draining arteries or the veins, but it's very important to locate the nidus accurately. So how accurately you can mark the nidus, that will tell the proper volume of the area that you are going to treat. There are a lot of literature regarding what should be the ideal image, like DSA, or should you use for CT angio or MR angio, or do you want all these things? Actually, we have done a small trial on what should be the ideal way. So we need all these things. Basically, we need DSA, we need MR angiogram, because all these gives different ideas about the proper nidus. So we use the information from all these images where neuroradiologists can help us a lot. And I think the real goal of treating an AVM, especially with the radiation therapy, has to be a complete obliteration of the nidus without any new development of any bleeding episodes. That is, as Durga rightly mentioned, it's a real challenge in the large AVMs or in eloquent locations. So even we know the Spätzle Martin grade, there are a lot of issues, because even we say that it's grade 1, it can be less than 3 centimeter or less than 1 centimeter. But if you look into the outcome, both are going to be totally different. So finally, it's always a balance, because as she rightly said, the good outcome at the cost of very minimal toxicity. And we all know, especially in our country, how hard for a family to accept the radiation therapy, even in a malignant situation. So in that situation, it's very difficult. It's a real challenge to counsel the patient regarding the need of radiation therapy in such a benign situation, and to explain them regarding the late toxicity. So I would say really it has to be a balance between how would you take the option of a surgical approach to a patient with AVM, or an embolization, or when to use judiciously the radiation therapy. That is the most important thing. So how to select patient for radiation therapy. So that has to be a most important part. So that's all from my comment.
Thank you very much, Dr. Rajeev. And to have a neurosurgeon's perspective on this, may I invite Professor Easwer, please.
Dr. Durga, very lucid talk. This is the first time that I'm hearing you speak. We have spoken over phone, but this is the first time. Good one. You started from the basics. You gave us a bird's eye view of things. The question that is under debate is not the grade 1 to 3 AVMs. It is a grade 4 and 5 and even the 6, the large hemispheric AVMs, where we're not able to offer anything. Unlike the patient that you showed when there was bleed, the dilemma that we face often is when you have a patient who present with a single or multiple episodes of seizures, where we don't know what the natural history is like. Is it masterly inactivity, or you should chase these AVMs and do something about it? This is a dilemma which strikes us in the outpatient clinics here. Your thoughts on that?
I wish I had an answer. See, basically, we would probably look at the age of the patient first and foremost, because before you give radiation therapy, that is one thing. I myself, in my limited experience and age, have seen at least 3-second cancers developing in patients I myself treated years ago. So when you see that, that is really, it really shakes you and makes you wonder what you've been doing. So as far as possible, young patients, I would try not to treat. But yes, if you think there is high flow, this thing, and there is a chance of bleed despite the seizure, then probably we should take the chance. It's only about maybe 2 or 3 per 1,000 patients, and that may or may not happen 25 to 30 years down the line. So instead of making a very young person go through life with this Damocles sword hanging up, maybe we should trust God and go ahead, blast.
Does the presence of a flow-related aneurysm in the AVM deter you from giving radiation therapies?
No. No, it doesn't.
Fine. All right.
Thank you. Thank you, sir. There is one, perspective of AVMs which we oft ignore. One specialist who we think is perhaps not so very important, and that is the neurologist. But probably the largest follow-up of the natural history of AVMs exists with our neurologists. And to give a neurologist viewpoint and perspective, I would request Dr. Ajith Cherian, who's got a large volume of experience in the management of AVMs, especially those with drug-resistant epilepsy and those who are incidentally detected or those who present with a single seizure. Dr. Ajith's neurology perspective, please.
Thank you, Dr. Josh, for inviting me. Am I audible?
Yes.
Okay. And madam, a very wonderful talk. I'll just touch on the neurologist perspective. Basically, there are two interesting entities. They can present to you with a headache, which can mimic just like migraine. So that is one entity about all these vascular lesions, whether it's Trivandrum venous angioma, AVM, or Dural AV fistulas. They can just present just like migraine kind of headache with phonophobia, photophobia, exercise-induced worsening. So for a neurologist, the immediate question is, should I image? So which are the conditions which will make you think of imaging? Basically, the first presentation is like a thunderclap headache. Even the migraine can sometimes fairly present with thunderclap headache. Then there's a definite entity you have to image. And especially if you have the patients saying that there's tinnitus all the time. And that is when you have to think, okay, there is either a dural AV fistula or a venous angioma which is lurking. And you, even if it's not well delineated in the image, you may have to go ahead with the DSA. And especially if they initially present with some signs of meningism, maybe, and if at all, if there's seizures, definitely you have to go ahead. Now, how to treat this kind of migraine-like headaches associated with this vascular anomalies? So the therapeutic trial I often give is basically topiramate. Topiramate has been the medication that I go to because it has both anti-seizure action as well as anti-migrainous effect. The other drug which has got anti-seizure and anti-migrainous potency is zonazamide. So these are the two drugs. I often don't use flunarizine. I go for either topiramate or zonazamide. Now coming to the seizure aspects, which are the drugs to be used? So if it's the elderly, I usually go for either zonazamide, lamotrigine, or brivaracetam. So these are my three drugs because brivaracetam I can use straight away because there is no titration that is required. You can just use straight away. So you can give a top loading on day one itself. If you are using either zonazamide or lamotrigine, and if you require titration, I use clobazam in the titration period. And in young individual, you can use the higher dose of topiramate, which will work both as an anti-migrainous agent as well as an anti-seizure agent at a dose of around 3 to 3.5 milligrams per day. And there are two interesting aspects which can happen after radiation, which sometimes may baffle a neurologist. Those two entities are known as the SMART syndrome, sometimes which you have seen, the stroke-like episodes with migrainous headache after radiation therapy, which can happen. So one should be aware that these entities exist. Otherwise, you may, in fact, be confused as to a new bleed would have happened or something like that. So especially if the patient has had a radiation therapy for a vascular malignancy or anything sort of, and the periatrial pseudo-progression which can happen after radiation. I think these are the things one should keep one's mind open and be aware of it because they don't require anything much other than treating with the anticonvulsants, steroids, and wait and watch. They usually resolve by themselves. Thank you.
Thank you very much, Ajith, for giving us a varied clinical perspective of AVMs. I also invite the honorable faculty and many other members of our audience to please switch on their cameras and feel free to ask questions or just share their experience. There was a question from Dr. Ajith. Dr. Ajith from SUT Hospital. Ajith sir, welcome. Okay. Please go ahead.
Welcome. Yeah, well, it's a talk really from the perspective of a radiation oncologist and doesn't consider what surgeon thinks about an AVM. I just want to say about you, people remember the treatment for tinea capitis long back is radiation. And later, after many decades, it presented with so many meningiomas. So as he said, it has started in 1987, and we didn't pass even 35 years. So the after effects and the dangers of this radiation will come out after so many years. So another thing regarding doctor is persistently saying the radiation for pituitary, because even when we started our career, almost 70-80% of pituitaries are sent for radiation. Now, with the advanced surgery, none of the lesions are, or very few indications and very few, 1 in 100 will be sent for radiation. So I have a question, technical question regarding this. You have shown a very large AVM, and it is close proximity to the sylvian area. So when you decide the ISO center, there is a chance that a normal vessel can be included in your radiation field. And later, as all you know, the effect of radiation will be manifested 2 years or after by the obliteration of the vessels. So how will you decide a normal vessel is not included in your ISO center when it's a large aneurysm which is in the close proximity to highly vascular areas like a sylvian or a middle cerebral artery branching areas?
Thank you, sir. The basic dictum of delineating the target in an AVM radiosurgery is to treat the nidus and only the nidus. Like Rajeev rightly pointed out, the easiest way to do it is get the neurosurgeon on board, get the neuroradiologist on board. So that 3 people's brain is probably better than 1.
But incidentally, have you ever have a injury for the normal vessel? But you cannot detect.
But probably we might see it in another few years also. Never seen it.
Okay.
Because usually they are thick-walled vessels. So even the radiation they say acts on the endothelial cells and causes all the clots and all that. If they're thick-walled vessels, it probably doesn't really matter. Maybe that's why.
Okay. Okay, thank you.
Yeah, I think
Dr. George, may I?
Sure. Please go ahead.
I know we're probably running out of time, but just with regard to the AVMs, of course, it's not possible to include all these variations. It's a very variable, clinical presentation for these lesions. But I remember the times when I was in Glasgow when we were contributing to the Aruba trial, and I was working with Rustam Al-Sahi, who was the main man behind the Aruba trial. But what would be the criticisms of the Aruba trial? What we now know from that and from several other studies. I think somebody's microphone is or somebody's talking in the background. Can you all hear me?
Yes,
hello.
Yes, I can hear.
Yes.
We can hear you well.
Yeah. So, what we have found is that partial treatment for AVMs doesn't work. I think that is one important take-home message for anyone who is dealing with AVMs, especially if it is an unruptured AVM. If in an unruptured AVM, if we are going to treat, you need to have a very good reason why we are treating it, and treating it partly is no longer justifiable. If you have sometimes you may end up partly treating it because at the outset you started off with a good intention of treating it fully, or you ended up leaving a part behind, which can but that is a different situation. But just going ahead and doing little bits of it, either by embolization or even radiosurgery or even surgery, I think is wrong, because a partly treated unruptured AVM, the natural history, you are making it worse than its actual natural history. It is a different game altogether when it is a ruptured AVM. So ruptured AVMs we have to treat, and in most situations, of course, sometimes we may not be able to treat it, but within the reasonable things available to us, the expertise available to us, if it can be treated well, yes, ruptured AVMs need to be treated. And in that situation is where, again, I think with a ruptured AVM, a lot of the time, I think, of course, again, depending upon the location of the lesion, size of the lesion. We may have different combination of things or each by itself. But one of the things which we used to follow was that the rupture risk from an AVM after it has once ruptured is quite high, not as high as an aneurysm or anything like that, but it's still high, maybe in the initial, maybe first year or 2 years. And the one problem with SRS or radiation surgery, as I know, is that it takes a little bit of time to get the AVM obliterated. It is not an immediate thing like neurosurgical excision or even embolization where the effects are pretty quick. So it does take a lag period. By the time it takes a time for the AVM to get obliterated, and during that time you are not completely free of the risk of rehemorrhage. So I thought I would just make that point. Maybe Durga has got something to add to that.
Yes, I think your second point answered the first point, as in why it is probably okay to treat with staged radiosurgery is because radiation takes time to act. So if you've treated one half today and you're treating the next half after 6 months, it's not like you treat today and it gets obliterated by tomorrow. It takes years for it to obliterate. So if you add the second dose pretty reasonably within the gap of this thing, then probably it is okay. Because there is actually a review comparing A versus B, and staged is supposed to be read. And I completely agree with the excision, if possible, scenario for a blood AVM, because it takes years for radiation to act.
Thank you very much, Dr. Durga, for that very, very fascinating talk, taking us to many, many corners of knowledge that we have never been to before. We also thank very profusely Dr. Rajeev, Professor Easwer, and Dr. Ajith, and all our faculty who expressed their views and comments here, and for all those who have just been around and shared their views with us. Thank you very much. We are very grateful to you, madam. We are also very happy to welcome many of our senior faculty who joined us in between, Dr. Mary Ipe, Dr. Shyam, and those others who are still with us, Dr. Krishna Umar, Dr. Sunil, Manjila, Dr. Jyothish. And I think the last word on AVMs, especially when there is a tough war between many specialties, is very difficult to be told in an hour's time. So I think we can continue the vascular discussion going, and it's my proud privilege to invite Dr. Vijay Jayakrishnan for the next talk on dural AV fistulas. This is a field where neurosurgeons have scanty knowledge, but they think they know a lot. And I'm sure that their knowledge will be expanded further by listening to this fascinating talk that is to follow. Dr. Vijay Jayakrishnan, please.
Thank you so much, George. It's a great pleasure for me to be here this evening, talking to a lot of old friends and colleagues, very distinguished faculty, around for this meeting. So I knew that will be the case. So that's why I chose this topic, because I didn't want the neurosurgeon to tell me I can do this better than you. I hope they will not tell me that, at least in this situation. Maybe I will be surprised. So here I'm going to share my screen, if that's okay. So thanks once again to the organizers. It's very rewarding to be part of this. So can I share my screen now?
Sure, sir. You can share. Please go ahead.
Can you see it?
Yes, we can see.
Great. Okay. So thanks once again. I think well, we are in Kochi, and you can see some of you may have been to the place visiting us, but here we are. It is somewhat picturesque setting that we are in. I think it's quite nicely surrounded by some greenery and some water, ways and things like that by the side of the Periyar River. So this is where we work. Okay, so I've got what I did was assuming that the audience would be a mixture of senior people, neurologists, neurosurgeons. There will of course be radiologists, hopefully, and some trainees, postgraduate students, etc. So I've made it into a mix of things. A lot of this is case-based, and also some discussions. Dural fistula is it's a complex subject, and you can divert, each particular area depending upon anatomically where it actually, focuses on. You can have a talk about that. So here I've tried to address the intracranial sort of dural malformations, which are opposed to the PL, the sort of AVMs which Durga will classically deal with in terms of, the radiotherapy and the surgical sort of expertise, and the endovascular, people will deal with the PL AVMs. We are a lot more familiar with them. When it comes to the dural ones, I think traditionally, I think these have been dealt with, for a long time by interventional techniques in terms of the management. So here there's a collection of things, lots of images here. We will try and go through some of these and address some of the imaging findings as well as the treatment options available for this fascinating group of conditions. When I say why I say fascinating is because they can present with various different problems. Imaging plays a crucial role. Angiography plays a crucial role in identifying what is abnormal, and clear technique-based treatment, which all adds to the sort of charm associated with it. And on the end, if you have done that properly, I think you can get rid of it. A lot of them, not all of them, a lot of them can be completely cured with very good, recovery for the patient. So it's a rewarding thing for anyone who is involved with the treatment of these conditions as well. So without further introduction, let me go to this case. This is a 49-year-old chap who comes with, hypertension. He's on treatment. He has been having hypothyroidism. He's on treatment for that. He has presented with a 2-month walking difficulty. Okay, so we do the MR, and what do we see? I think it is obviously, the abnormality is very obvious in the basal sections here. This is a T2-weighted image, and immediately see this whiteness or wetness of the brainstem, the pons, and going into the medulla. Okay, and up into the upper pons. And these are the sagittal images. You can see the extent of the abnormality. This is the brainstem and the cervical cord. The whole thing is affected. There is some swelling of the medulla and the lower pons as well. And this is the axial image there showing the lesion. So what could this be? I mean, I think in the normal situation, I think you would call this as a possible inflammatory problem. I mean, I think there was some patchy enhancement after contrast. So, is it some sort of myelitis? This could be a type of neuromyelitis optica, for example, some other inflammatory process. We have seen things like sarcoid sometimes can produce conditions like this. But the patient is already on treatment with steroids and his symptoms are worsening, so it's a little bit against this being an inflammatory abnormality. And then we consider neoplastic. That is also possible, but most neoplasms in that location, you would expect some kind of enhancements, quite strong enhancement, but that was not there in this case. So we discussed this, and then we looked at these images a bit more closely, and you probably would have already spotted it, and you can see a little, few what you call flow voids on MRI, little small dark channels here in front of the cord, of the cervical cord there. It's not very clear on the axial images, but it is there, and again on the the coronal images here, blown up, you can clearly see a little corkscrew-like channel running there in the midline. Okay, now that is all that you need to suspect a vascular abnormality underlying this. And then, of course, at this point, you have to now go and to do the confirmatory test, which of course is a conventional digital subtraction angiogram, right? And you do that. And as I emphasized at the beginning, I think the technique is absolutely crucial. And here in these sort of situations, very meticulous attention to detail and looking at the abnormalities as they surface on the screen is extremely crucial. So here we have got the catheter into the external carotid artery on the right side. And even in this sort of non-selective external carotid injection, you can see the abnormality. Tiny one here, and then you can see this vein filling. Okay, so this is the AP view. So this is the midline, that is the spinal canal. So the vein is going into the spinal canal. And that is the corresponding vein we saw on the MR. Okay, you can see that there. You do more close-in views. This is the lateral view here. Okay, again, we can see this abnormality filling in the posterior fossa. Okay, and with its venous drainage, you can see as we go into the venous phase, the vein, abnormal vein is very obvious there. Okay, so now to delineate it further, you do super selective runs into the involved branch, which I think is the ascending pharyngeal. And here you can see this, the little nidus of this malformation, which is supplied by one of the dural branches coming off this ascending pharyngeal artery. You have got a little nidus there, okay? Nothing much to speak about, but it is there nevertheless. And then you have got a vein coming and draining all the way into the spinal canal. There it is. Okay, that's on the lateral view. That is the vein. There's a small channel posteriorly and a larger venous channel anteriorly. So this is what is causing the patient his problem. He has got an arteriovenous fistula or a dural malformation. It's not really a fistula. When you say a fistula, you almost imply something where there's a rapid shunting between an artery and a vein. These are not rapid shunts, and these are actually maybe multiple small areas, almost like a nidus, which is formed by supplied by the dural branches there, and then draining through these veins, which are interfering with the venous drainage of the medulla and the spinal cord, causing a retrograde venous congestion and venous edema in the areas affected. Okay, so that is what this patient has. And what can we do for him? Of course, the treatment is endovascular, and here the approach is definitely through the artery. So you go with the artery into the artery further, distally using microcatheters. And once you are in the proper position, as close to this abnormality as possible, then you can obliterate it. And a lot of the time, you need a liquid embolic agent. It doesn't really matter what liquid embolic agent you use. I used something called SQUID, which is a DMSO dissolved, embolic agent similar to Onyx. You can use the classic blue, which has been in use for several decades before all these newer material came. You can use blue as well. The important thing is to, of course, angiographically always keep looking for any abnormal communications. And here in this location, the important abnormal communications that you can have are with the vertebral artery. Any of this can percolate into the vertebral artery. So careful angiography and careful injection it cannot be overemphasized in these sort of locations. Right. So these are pictures from the embolization. You can see the little cast. This is not like a big blue cast that you get with AVMs and things like that. It is so small, and but that is all that is needed. Okay, you put it in the right location, and what the technique of injection of this is also very crucial. You have to, there is no point in obliterating the artery. You have to make sure that whatever you are trying to penetrate, it penetrates into the malformation, and then you also get the vein. The proximal vein, or what you call the foot of the vein, has to be also obtained for a good closure of this condition. Otherwise, chances of recurrence are quite significant. So this is the patient pre-embolization, same patient. Okay, you can see the extensive changes in the brainstem, and this is at 4 months post-embolization. And you can see how the brain is returning to normal now. It's this is again the pre, where you can see the abnormality, and then at 4 months you still see a little high signal in the cord, but most of the brainstem has returned to normal. This will improve over a period of time, and the patient symptomatically improves almost very soon after the procedure. So moving on to another patient, fairly close by after the first one, this patient turned up. And the area of abnormality is pretty much the same. Okay, so here we have got abnormality again in the pons. It looks very swollen with abnormal signal, and there is abnormal signal in the adjacent cerebellum as well. The difference in this patient is that there is some heterogeneous signal there, and what is that due to? This is the so-called gradient or susceptibility imaging, and those who are familiar with this will immediately recognize that this is blood. Okay, so this lesion has already hemorrhaged into the brainstem. That is not very nice. So we have got diffusion imaging, etc., which tell us there is ischemia going on, and then there is also hemorrhage that has happened into the lesion. Okay, and again we go with the selective external carotid runs. This is the occipital artery lateral view, and probably again a branch coming. You watch that carefully, and that peters out at the skull base into this abnormality. Can you see almost like a crow leg appearance? A little tiny thing. That is the abnormality, and look what it has done. So this is the dural malformation there, supplied by this branch, and then you can see this vein coming out of it. Okay, and where does it go? So this vein is going cranially, and then it is refluxing back, and you see all this refluxing into these veins, and these are all veins which are trying to drain the pons and the brainstem. And the normal way, the venous channel is retrogradely pushed by this arterial pressure, and the pons is suffering. And it has undergone, and maybe one of these venous channels has given way, leading to rupture in the brainstem. And again, treatment pretty similar. You go super selective into that and inject this liquid embolic agent, getting a cast of this nidus and the foot of the vein, and the condition is treated. So those are two examples. So going into this topic, AVMs, intracranial dural AVMs, we are going to talk about. We know what we know about as compared to the PL, AVMs. We know that dural AVMs are acquired AV shunts, and a lot of them, happen in adulthood. They represent about 10 to 15% of intracranial arteriovenous lesions, and most of them will have supply from the dural or the meningeal branches. And this could come from the external, come from the ICA, or from the vertebral. All these arteries have got dural supply, and the malformation may be supplied by any of these or all of these. Okay, and the symptoms depends upon the location of this lesion, and dangerous symptoms develop because of arterialization of veins, as I showed you before. Okay, the veins get arterialized, resulting in back pressure, and they succumb at a certain pressure point, leading to hemorrhage in the brain. Why do they occur? We are still not very clear about it, but what we know about them are there is a lot of interest in venous injury, which is leading to development of dural AVMs. There are papers which have been published where we can see venous thrombosis followed by development of dural AVMs. So something that triggers angiogenesis after thrombosis or trauma in the venous side, usually with the major dural sinuses, and sometimes these channels go a bit haphazard and result in these malformations. Now, they can occur anywhere where there are veins and anywhere there is dura mater. And the most common ones we find are at the level of the cavernous sinus. And here I'm not going to talk about the direct carotid cavernous fistulae, etc., but more the sort of dural malformations that primarily affect the cavernous sinus region. Of course, we are all familiar with the transverse sigmoid sinus region, which are very common sites for dural venous malformations and fistulae, dural arteriovenous malformations and fistulae, and along any of the other sinuses as well. They can be asymptomatic. You can incidentally come across some of these. The classic location for incidental are the ones under the frontal lobe, the ones where you have small supply coming from the ophthalmic artery or from anterior cerebral artery, some of the dural branches, and then they drain into the sagittal sinus. A lot of the time they are asymptomatic. Sometimes they can produce the typical gyrus rectus hemorrhages where you may have to treat them. I said about the symptoms, they're usually due to arterial pressure on the veins. Patients can, depending upon the location, the classic presentation with the ocular symptoms if they are related to the cavernous sinus, diplopia, etc. Tinnitus when they are located along the transverse sigmoid sinus. Hemorrhage can occur secondary to any of these, location. And we know that the real risk is directly related to the venous drainage pattern. We will emphasize that with a few examples as we go along. There are lots of classifications available, but practically, I think this one the earlier one by Gigian and Merland, and its modification done by Christopher Conniard from France. These are the two classifications which we generally use. And this classification, again, has a lot of emphasis on how the veins are affected. So whenever you have got the fistula retrogradely refluxing into cortical veins, that is a dangerous sign and an aggressive pattern which needs to be more, obviously treated. Rest of them, it depends upon the symptoms. Some of them may have a very benign looking appearance for the fistula with no cortical venous reflux. Everything, the shunt will drain in the normal direction as the normal veins do, but the patient has got disabling tinnitus. Sometimes the patient cannot sleep at night. The tinnitus is interfering so badly with when they're resting. So those are the times when you have to probably treat the asymptomatic ones as well. This is just a picture representation of Conniard's classification. And this one where the 2B, where you have got this cortical venous reflux, look out for those ones. And these are the ones which can, lead on to real difficult problems like brain hemorrhage. So, yeah, this is just, again, what we discussed. And I emphasized on the importance of angiographic evaluation. And that has to be, and this is one situation, I think, where we don't get much out of doing a MR angiogram or a CT angiogram. I mean, if it is a very large, like a fistulous communication, you may be able to identify the artery, vein, etc. on a MRA or a CT angiogram. For all the other AVMs or dural AVMs, you need catheter angiography. Okay, just a table saying, I mean, I think I need not go into the details of this. And I think the audience here should be fairly familiar with what sort of symptoms these patients can present with. It depends upon the location of the malformation as well. Okay, so technique, I mean, I think we need to have a very meticulous attention to detail for these angiographic, investigations. That is what we usually do. All these, branches need to be studied. We have to use adequate amount of contrast. Frame rates are important. Some larger, shunting lesions will need larger frame rates. And in all these things, we are also trying to identify the normal venous anatomy of the brain. Okay, you have got an abnormality, but another very important thing that we need to, apart from mapping the abnormality out, we need to understand how the normal brain is draining. Okay, is it using those pathways which are already affected by the malformation, or the brain is already taken care of through other pathways? Now, this is a very crucial information for planning treatment. So just the cavernous sinus dural AVMs, again, fascinating condition. I think, you often have patients presenting with ocular symptoms, red eye, and a lot of them present to the ophthalmologist. I think almost all of the patients whom I have treated were seen in ophthalmology, sometimes by neuro-ophthalmologists, red eyes, proptosis, cranial nerve problems. They, by and large, the aggressive symptoms are a bit rare. Intracranial hemorrhage is rare, but can, very well happen. I will show you an example. They usually have a benign venous drainage pattern, and spontaneous regression can sometimes happen with the slow flow AVM, so the dural malformations affecting cavernous sinus. Some people recommend treatment like pressure over the eye, or sometimes pressure over the carotid artery. I have examples where it has worked, and and where things have spontaneously closed after like after seeing them in the clinic and planning for angiogram in the duration. It has disappeared, and you have a normal angiogram when you do the DSA. So when you can have a conservative course, but you have to always remember that if something check angiography will be still useful, just to make sure that you have not got a condition which has changed its drainage pattern. Okay, something was using the eye veins to drain, and you have got congestion, redness, proptosis, etc., and that has disappeared. That we should not always take that for granted that the lesion is gone. It may be useful to at least do an MR angiogram, or, with high resolution. Make sure that there is no other channels or the brain veins which are being used by this lesion. Okay. Now, these lesions, of course, we can use several ways of treating them, but most of the time, when the cavernous sinus is involved, we are going to resort to a transvenous embolization of the sinus if you can get access into the sinus. Sometimes you may not get access into the sinus, where you may have to go transarterially, okay? But transvenous embolization works very well if you can find an access. And most of the time, what we find is that the venous channels are blocked. So the cavernous sinus, as you know, drains backwards through the superior petrosal and inferior petrosal sinuses, and they join the internal jugular vein. You can get through that into the cavernous sinus, but a lot of the time, these venous channels may be blocked. But prodding with catheters and wires often gives you a channel to get into the cavernous sinus. And once you are into the cavernous sinus, you can pack it, usually with coils. I prefer coils. You can also use liquid material. I would not use glue, which is a typical, the blue glue or the histocryl in the cavernous sinus, because of the fear of causing damage further to the cranial nerves. But people have used squid or onyx in the cavernous sinus with good results. I prefer coils. If I can get packing done with coils, that's what I would do. This is a nice picture of the cavernous sinus. We often talk about the cavernous sinus. We can see it on cross-sectional imaging. On angiography, most people will not have seen the cavernous sinus. This is where it is. Okay, this is the lateral view. That's the cavernous sinus, and coming backwards, this is towards the back of the skull. Those are the petrosal sinuses, the superior petrosal sinus, and you have got the cavernous sinus, the venous channels that drain into it. This is the superior ophthalmic vein. That's the orbit. Okay, that is the orbit there on the lateral view. This is the inferior ophthalmic vein, so they come and drain into the cavernous sinus. So whenever you have a fistula happening into the cavernous sinus, what happens is that there is retrograde flow into all these. Okay, whatever drains towards the cavernous sinus now starts draining the other way. So the superior ophthalmic vein starts filling the other way and starts to flow into the jugular vein through other routes, and that is when you get the proptosis and the redness and the ecchymosis and all those things. So this is typical appearance on CT, and this is an exam sort of slide for a lot of radiology exams where you have got usually no abnormality, but when you look at the orbit, you see an enlarged superior ophthalmic vein, and the abnormality usually is a cavernous fistula. And this is what you see on the angiogram. Okay, there are a lot of blood vessels which are supplying this at the level of the cavernous sinus. You can see it, filling with blood and then emptying through retrogradely through the superior ophthalmic vein, causing the patient problems. And you can see some brain veins filling here as well. So the sphenoparietal sinus is also getting a little bit of reflux in. Okay, so treatment, of course, is transvenous. You go through and get into the venous part of the cavernous sinus and block it with coils. This is a patient with, again, with a dural malformation center. There are multiple dural channels here, okay? So you cannot really target these through going through the arteries. You may be able to, if there is no venous route, just getting particles, etc., but they usually work temporarily. But here, again, you can see the fistula fills, or the malformation fills the cavernous sinus, and here it is draining posteriorly, and you can see these little squiggly veins. They are cerebellar veins, okay? So not all of them are benign. Some of them can have this aggressive pattern where there is already reflux into the brain veins. And again, treatment would be through the sinus. So post-transvenous occlusion, something to be watched out for. They can develop pain because you are blocking the sinus, and the sinus develops some thrombus, and there can be pain that is very much expected. They can have new diplopia or some increase in diplopia. This is also transient, usually disappears. I usually symptomatically manage them, may give some heparin in small doses, maybe continue it for 1 or 2 days, and usually they get very well. A short course of oral steroids may be tried as well, but a lot of the time they are self-limiting and the patients start improving. So here we have got a patient, this is the T2 weighted images, and you can see this abnormality in the cerebellum, and again from the signal we can very well see that this patient has already, so I told you, they can, even if the abnormality is at the level of the cavernous sinus, you can have hemorrhages in the brain, and this patient has already developed a hemorrhage into the cerebellum. And the abnormality, again, here you can see the huge dilated superior ophthalmic vein on the left side, and the enlarged cavernous sinus. This is with contrast MRI. You can see the enlarged cavernous sinus on the left side, which gives you an indication that there is something going on there. And of course, when you see this, there is a fistula or a malformation center there. And that this is causing a brain hemorrhage. And here we are, the same patient, when we did the angiogram, you can see from the right side, actually the cavernous sinus onto the opposite side is filling on the left side. Okay, there are through the trans, cellular communications or the intercavernous communications, you can see that there. And then we get, again, to cut things for time, I think, we accessed it through going through, you can see this catheter here. This is in the jugular vein, okay? From the jugular vein, you go through the petrosal sinus, you can see the catheter going through the petrosal sinus, and then once you reach the cavernous sinus, you can start right from the lower part or the proximal part of the ophthalmic vein, coming back into the cavernous sinus and packing it nicely, and that is the fistula closed. So moving on, another common area is the transverse sigmoid sinus dural malformations and fistulae, very common. Patients present with tinnitus, they can also present with seizures, hemorrhage, all sorts of things. And these are the refluxing veins which make it dangerous. And these are usually, most of them are high flow. And as a secondary to that, after a period of time, when you have fistulas which initially can drain the normal way, just as a normal sinus will drain the brain. But soon you will start developing some venous stenosis and venous occlusions, and sometimes the sinus gets isolated. Okay, it gets cut off, and you get almost like a small island there. And then this is only supplied by these arterial channels, and then you have got this venous reflux happening. So this is all a progression of things that can happen with this type of fistulae. Treatment again in this location, you can again, the same principles apply, conservative, you can reduce the symptoms by embolization if you want. And also sometimes when you want to prevent hemorrhage, especially if there is venous reflux. Angiographic evaluation, again, we emphasize the importance of that. Treatment, again, it can be transvenous going through the sinus if you have got a sinus access, and then the point of whether that sinus is actually being used by the brain. So this is what we are trying to understand from doing the angiogram. If the involved part of the sinus is not used by the brain, and the brain has already, in most of the situations, especially when there's high flow going for a long time, the brain would have rerouted its venous return using other channels to drain, and that the sinus will be just fed by these fistulous branches and just refluxing. So in such situations, you can be a lot more aggressive. You can block that sinus either using a variety of techniques, transvenously get there, transarterially get there, and block that communication using glue or any liquid embolic agent. Coils, you can block it off, and without compromising the venous drainage of the brain. So that important information you need to get from your angiographic evaluation. Now, there are situations where getting into this venous sinus or the occluded, when it is completely occluded, getting into a venous sinus or the venous sac of the fistula can be quite difficult. And I have used surgical surgeons to work with me, and they can do a nice little burr hole, just very carefully when this it is quite peripherally located, this sac, and then you can put a little Venflon or similar catheter through that burr hole into this thing, and then put a microcatheter in and get the same result. So these are typical presentations, patients presenting with hemorrhage like that. Okay, in any patient, adult patient, these are abnormal hemorrhages. You need to have a cause behind. You have to exclude something that has ruptured. It could be an AVM, it could be a dural malformation, it could be a cavernoma. These things have to be excluded. So you have to, a lot of the time we may just do a CT angiogram, MR angiogram. If they are sensitive enough and if they have been interpreted properly, probably okay. But if you have got an element of doubt, don't hesitate to do angiography, because some of these lesions can be quite small and will be shown only by proper angiography. And you can see this abnormal dural branch. This is a meningeal artery coming backwards and then ending into this fistula, and draining into this fistula is then draining into the brain veins. And that is why it has ruptured. And treatment is very straightforward. You can get a microcatheter as close to the fistula's communication here as possible and obliterate it. Okay. The tentorial dural AVs, these are again more dangerous type of AV fistula and malformations located along the tentorium. They are deep-seated, and then you can, of course, they are most of the time associated with the retrograde drainage into venous circulation and of the brain, and they are most of the time associated with a high risk of hemorrhage. They present with hemorrhage. So things like this, where there is a acute hematoma, and you do this and you identify this fistulous lesion, pretty similar to the previous one. And identification is the most important, and then you can treat it very elegantly, going through the blood vessel. This is transarterial. There is no way you can go transvenous for these lesions, because they are miles away from where the sinuses are, and these veins are so friable. So any attempt to navigate these sort of veins, you are asking for trouble, causing catastrophic hemorrhage in the brain. So these lesions have to be approached through the artery, getting as close to the fistula as possible. And nowadays we have got several additional techniques. Even if you are a little far off, you can use different types of catheters, and we have got now very small catheters with balloons within them, or you can inflate the balloon, and then that prevents anything refluxing back the way. Okay, you need to be fairly close to the lesion as possible, and the balloon will help to penetrate this further forward, whatever material we are injecting. Another tentorial dural AVM, multiple arterial channels, all of them, but they are all communicating into this little small venous pouch here. Okay, once you have that, then it becomes it's all communicating there, and you can see this big venous communication into the straight sinus. Okay, and then it is draining into the the transverse and sigmoid sinus. So look at these arteries. This can also happen. Okay, these are not straightforward arteries. These arteries are extremely tortuous. There is absolutely no way you can navigate a microcatheter as distally as possible. And if you keep a microcatheter somewhere here or here, you are not going to get this part. Okay, you absolutely need to get this part where this is the end point where the fistula is communicating. Okay, all these fistulous arteries are coming and joining here. So whatever you are going to do, you have to obliterate this bit. If you obliterate here, the artery, it is not going to work. So what can you do? You don't have access to the artery. These are the ones where you have got a large vein, fairly straightforward venous channel, and you can go through the vein, and that's exactly what we did. We went through the venous side, through the transverse sinus, into the straight sinus, and once you are into the venous, that pouch, you block it with coils, and that's all it takes. Okay, all these channels shut down, and the fistula is cured. So this is a patient, again, presenting with gyrus rectus hemorrhage, which I talked about that. You can see that there's a little bit of intraventricular hemorrhage as well, but the main hematoma lies in the gyrus rectus. So when you see that, and if there is no history of trauma, always think of the underlying AVM or a dural malformation. And these are classical, sort of subfrontal AVMs supplied by branches of the ophthalmic artery. And this is one area where Of course, the surgeon has got, we definitely would like the neurosurgeon to attack this if possible, because it is not easy attacking these endovascularly. You may do if you have got a good channel coming off the ophthalmic. A lot of the time, there, as the typical dural branches go, they are very corkscrewy, and you may not be able to navigate a microcatheter distally. You may be able to come through the venous side and attack it retrogradely, but this location and the position of this malformation is usually amenable to surgery, and that can be very well be tried. This is embolized with a good result. Okay, so anterior fossa AVMs. There we are. And this is again, we saw examples like this. So posterior fossa dural malformations with the venous drainage interfering with the venous drainage of the cord, presenting this sort of myelopathy. So always think about it. Here you can see this abnormality again. This time it is fed by small branches here. Some of these ones, I mean, I think maybe not this one, but in the talk on radiotherapy, there is a lot of, I mean, SRS has progressed so much. I mean, I think in the last decade there is a increasing interest in dural malformations, especially the asymptomatic ones, especially the non-hemorrhage or the non-ruptured ones, where you can have symptomatic reduction with the SRS. I think it is there very much. Now, coming to the end of my presentation, these are, of course, the nightmare for anyone. Now look at this picture. I mean, I think this patient, is having this, when the patient presents interestingly with dementia. Okay, and the neurologist here will recognize this immediately. This patient has got deteriorating mental and cognitive, capacity, memory function, and you do the imaging and you find this. And what is this? He has got vascular channels everywhere in the brain, everywhere. Okay, so these are multifocal, multiple AV malformations, dural malformations with venous. What channels we are seeing here? These are all veins. Okay, all the veins into which this retrograde flow is happening, and the congested venous channels, and this is leading to this dementia. Contrast to MR is more dramatic. You can see all these venous channels, everywhere in the brain, and this is a typical, predictor for a high, flow fistula with multiple compartments in it. This is just one compartment centered at the level of the durals of the transverse sinus. Here you can see how it fills with these tiny, multiple branches coming into it and filling it and draining into the jugular vein, and there is a lot of venous reflux as well, not very well shown in that. But just to also, I'm not going into the technical details, but the armamentarium is expanding all the time, and now we have also got venous balloons, the compliant venous balloons. This one is called Copernic RC, which you can actually, if you actually want to keep a sinus, you want to preserve the sinus. So the danger of injecting anything there, even from the arterial route, is that the sinus may get blocked. And if the brain is also using that sinus to drain, that is not a good thing, because the patient may further develop a venous infarct in the brain. So if you want to really preserve the venous sinus and inject from the arterial end or even along the side of the balloon, that also is possible. You can use these sort of large, long venous balloons into the venous sinus and utilize that. This patient I treated with that sort of approach. So I kept a balloon inflated in the sinus, and then from the side of the balloon injected a liquid embolic agent, which penetrated into all these abnormal communications. You can see that the central area where the balloon was kept, and then all these sort of communications filling up with onyx once you start injecting it, and then you can get a good result. Some of these multiple ones are extremely difficult to get rid of, and we probably shouldn't even aim for that. I think what you want is to reduce it as much as possible and re-establish normalcy. And you can see this these large channels in this patient's brain, and this is after treatment, and you can see how they are coming down, and all these venous channels they're still there. Some of them are still there, but they have reduced in size and number significantly. Right, again, here this is a patient who just walked into the clinic. Okay, difficult to believe that, but she just came in with a bit of headache, and you do the MR, and you can see this huge lesion here, which is already hemorrhaged. Okay, so this is venous hemorrhage, venous ischemia, venous in low pressure. So that is why the patient is still not that symptomatic, and the brain is accommodating with the changes around it but there is definite hematoma there. And this is MRV, as I told. I mean, a lot of the time it is not very useful, but look at this, a nice demonstration of this big artery going from the meningeal vessel. Okay, this is the middle meningeal artery or the posterior middle meningeal branch going all the way back, and it's all, actually you can see this, you know, big communication here. That is the fistulous communication with a huge venous pouch filling there. Okay, and once again, this is the artery which exactly looks similar to that. Okay, that is the meningeal artery, middle meningeal and posterior meningeal branch from it, and here you can see the communication. And once you look at the veins diverting back, so this is the filling of the sac. And from the sac, it is all emptying. All these veins we are seeing here, they're all brain veins, okay? So backflow into the brain veins. And treatment, again, transarterial, get as close to the fistula and inject liquid embolic agent, close the venous sac, and that is all it takes, and the patient is cured. So liquid embolic agents we use mainly, coils, we talked about it. Transarterial is usually with liquid embolic agents, very rarely particles. We use the balloon catheters and all of them, which are all DMSO compatible, because most of the newer methods newer materials are mixed with the DMSO, which is dimethyl sulfoxide, which actually can dissolve plastic, if you know. So most of the standard catheters you cannot use, so you need specific catheters for use with these sort of embolic agents. And you have got these long venous catheter balloons. I told you about the Copernic anatomy changing. So one important thing to be emphasized, I think all the interventional guys will know about this, is the anatomy that changes during embolization, especially when you're injecting things like the occipital artery, especially when you're injecting the middle meningeal artery, because there are a lot of dangerous anastomosis. And this is not the place to go into details of that, but all these internal to external communications between the internal carotid artery and the external carotid artery, between the vertebral artery and the external carotid artery, between the ophthalmic artery and the internal and external carotid artery. So all these things you have to watch very carefully during embolization. It cannot be emphasized how much you need to look for these things and avoid things from going as close to these communications as possible. So summarizing, so we suspect them on imaging. These are a fascinating group of conditions. We confirm them on catheter angiography. Treatment, I would say that still remains almost always endovascular. And you need good quality images, angio techniques, paramount importance. We can achieve high success rates, with very good cure rates for these conditions. So that's the end of my. I hope I have not overstepped the time. And thank you for listening.
Thank you very much, sir. It was a very brilliant talk, taking us to many aspects of dural AV fistulas, which I'm sure many of us, even the senior faculty, were not very familiar with. I can sense that sense of fulfillment in our radiology and neurosurgery residents who have got so much of information to write a gold medal or a distinction answer for a short note on dural AV fistulas. Thank you so much. May I invite Dr. Jayadevan, an expert with a wide body of experience in dural AV fistulas, to share a few comments, please.
Thank you. Thank you very much for a very wonderful talk on dural AV fistula. So this thing is that dural AV fistula, it's a very difficult one. As a neurointerventionist, it is one of the very difficult intracranial vascular malformation to deal with. So mainly because of the presentation, varied presentation. Most of the time we will not be understanding what exactly. And the imaging also, sometimes it is very subtle. Say imaging, it will show some very small vascular malformation or some prominent blood vessels in the subarachnoid spaces or some white matter edema, that much only. So the important thing is that strong clinical suspicion is always required for to diagnose this dural AV malformation. And the most important thing is a good cerebral angiogram. So I think the Dr. Vijay has already been emphasized on that. Good cerebral angiogram, that is actually 6-vessel angiogram. That is both ECA, both vertebral artery and both ICA meticulously we have to do. And that also even some super-selective or selective injection also have to do. This is mainly to identify the feeding artery and also for the veins. So in the dural AV fistula, the veins are more important. So we have to identify the complete the venous anatomy and even the circulation time of the cerebral circulation, anterior and posterior circulation. So these are very important. This has to be thoroughly studied. But compared to any other vascular lesion, the entire brain vasculature we have to study it thoroughly before going ahead with the management. So when you talk about the management part, so as he has mentioned, so we have both the transarterial and transvenous is there, but generally preferred one is a transarterial. But when you see the transarterial, if you have a middle meningeal artery, you can embolize the fistula almost near complete or complete embolization. But when the feeders are coming mainly from occipital artery, ascending pharyngeal artery, or from this ophthalmic artery, or from posterior auricular, then you cannot embolize it completely. So that is the other thing. The transvenous embolization is generally preferred mainly for skull-based midline dural AV fistulas. The other convexities, dural AV fistula, generally we prefer transarterial embolization. The other important thing is that when you have a dural AV fistula, which is multi-compartmental and angiographically, it is not contiguous and they are not continuous. So you will not be able to embolize it completely in a single sitting, or sometimes it is a complete embolization is not possible. And in a similar way, the dural AV fistula, which you are seeing in the pediatric age group and also in younger patients, in this situation also the complete embolization is not always possible, because they are more of a developmental rather than a acquired one. Of course, the theories are a lot of theories are there. So that is a difference. So another thing is that regarding the post-procedure, most of the patients, we have to put the patient on anticoagulants. Because of that, there can be a chance of recruitment of the artery. So always we require a check angio at least 3 to 6 months after the procedure. So this is a very complex disease to deal with, because strict angiographic evaluation, planning of the embolization, then after the post-procedure planning, like anticoagulation, then post-procedure meticulous angiography. All these things are required to treat the disease. So sometimes we may not be able to completely treat the disease. At least we can reduce the grade of the disease so that further symptoms and hemorrhage can be prevented. So it was a very wonderful talk by Dr. Vijay. So it is really nice to see all the very nice descriptive cases. Thank you very much, sir.
Thank you very much, Dr. Jayadevan, for sharing that wonderful perspective. May I request Dr. Jyothish to give the neurosurgeon's point of view, also Dr. Sunil, Manjila, and Professor Easwer, please.
Very well presented, Dr. Vijay. And as George was saying, we neurosurgeons have a very scanty knowledge about these dural AV fistulas, mainly because we seldom come across these lesions nowadays. And the surgical indications are limited to mainly the moidal and the superior petrosal AV fistulas. And my doubt is whether these rarity, whether it is due to actual rarity of the lesion, or we are some of the lesions are gone undiagnosed, mainly because we evaluate these spontaneous SDH and also spontaneous bleeds with in MRI, MR angiogram and CT angiograms mainly. Some of them we don't get any clue regarding that. Yeah.
No, that's very good point actually, Dr. Jyothish. I think there is a good chance that some of these may be overlooked. Like when we do CT angiograms or MR angiograms, because the lesion can be extremely small and it may not fill with the venous sort of injection of contrast that we are giving on a CT or MR, MR venogram, MR angiogram. Of course, it is sometimes you don't. It's a flow dependent technique. So if there is no high flow and if there is no large lesion, like the one example I showed you where there's a huge venous sac, if that is there, then you pick it up. But if it is not there and the patient has just had a hemorrhage, and you did, if you don't do proper angiography, there could be the lesion could be missed. So that is the emphasis on, I mean, I think any patient who presents with a not the usual type of hemorrhage for a hypertensive hemorrhage, because we have got typical patterns for these things. So pattern recognition is very important. I think that is what I usually tell my postgraduate trainees as well. So there's a pattern for a hypertensive hemorrhage, and if it doesn't fit in, even if the patient is hypertensive and the patient is above 60 years of age or whatever, if the hemorrhage pattern is not fixing it, we don't lose much by doing an angiogram. I think in the ideal clinical situation, I mean, of course, we all work in different sort of, environments, and it may not be the same in all parts. But what I would say is that, from at least from an academic point of view, there should be a complete investigation should include a cerebral angiogram for these patients. Whenever you suspect that a hematoma is not actually matching what we are, if we are thinking of a hypertensive, what sort of bleeds can happen in patients who are, these are generally, I think, the dural malformations, apart from the PL fistulas and dural sort of end-hole sort of fistulas and things, which can sometimes happen in children. By and large, this is the disease of adulthood. We usually see it after, I cannot really remember patients who were less than 30 years of age coming with the dural malformations and things like that. Most of them are into their 50s, 60s, 70s. Also, the time when you develop hemorrhages due to other problems like amyloid angiopathy or cerebral, hypertensive hemorrhages, etc. But high index of suspicion is the most important thing. And unfortunately, a lot of the places will do CT angiography and MR angiography, but they may not have access to catheter angiography. And to answer your question, I do think some of the cases that may be getting missed, and they represent with hemorrhage if they are lucky in a good clinical stage, and then probably the thinking becomes more clear.
One more note regarding those cases incidentally detected when there is no cortical venous reflex. How do you follow up these cases? Whether you have to leave them alone or you have to follow them regularly?
That's a very good question. I think in terms of the change in architecture, I mean, I think if it is for any patient who is coming with symptoms, I mean, I think a lot of the time it is ocular symptoms. If it is a cavernous centered cavern, you can almost predict. So if they are coming with ocular symptoms, we would definitely treat them. Okay, even if like it may be mild diplopia, it will be even if they have not had a hemorrhage or anything like that, because a lot of the time the symptoms are disabling, and the longer you leave them, the more chance of the nerve damage being more permanent. And also there is a lot of the patients will have a cosmetic reason to treat as well, because eye will be red and it will be bulging. So cavernous sinus, even if they are presenting with these sort of symptoms, we will treat them. The other ones are where patients are presenting with unruptured fistula, but with symptoms. Classical one is tinnitus. So the tinnitus, I think I would evaluate them. I mean, I think with if a lot of the time you may be able to see some features of it on imaging, but to exclude any dangerous component, you still need to do angiography. Once that is excluded, then it is a matter of sitting with the patient and discussing actually how troubling the symptoms are. If the symptoms are too troubling, then you probably would have to try and treat it, reduce the flow at least, and help the patient. If they are not very symptomatic, comes to your question of how soon we should re-image. Now, there is no real answer, no evidence-based answer to that. I would say that it will be useful to warn the patient for any change in symptoms. Say, for example, a seizure. Definitely the need to re-image, re-angio the patient, because it indicates that there is something else is happening. Maybe a venous return has changed. If the patient has not any change in symptoms, I would probably do an MRI, maybe, just to keep everything under control, maybe once in 2 years or something like that. But that is, purely subjective and, not evidence-based.
Okay, thank you.
Can I add one point to that, sir? Yeah. So what we for asymptomatic one, what we generally do is we do the MRI. The thing is that conversion of asymptomatic, that is non-aggressive dural AV fistula to aggressive dural AV fistula, is very rare. It's not very common. But still we do MRI maybe after a year or something. If any cortical venous reflex is happening, we can detect it with the susceptibility vein imaging. In that, there are changes in the brightness of the vein we can identify. From that, we can identify that the patient has started the cortical venous reflex. So that is an indication of patient is shifting from low grade to high grade. So that is the one thing. So with the MRI, probably we can follow it up. Otherwise, usually symptomatically only.
We are eager to hear from Dr. Sunil Manjila, who is connecting
Thank
to us
you.
from Connecticut.
Thank you. George, it was a pleasure seeing all these faces whom, I had met many years ago, Ajith, Easwer, all those friends. But I'll tell you, I really enjoyed, I sat through the entire presentation. I just wanted to become a fly on the wall, go unnoticed, but you throw me out in the open. But now I've got to say something. Now, first of all, wonderful presentations. A couple of things, a couple of questions for Vijay. What microcatheter did you use for the first case that you presented, and where did you park it?
The first catheter, I think, for this small, malformations, that was one of the skull base which was draining into the spinal, venous.
Yeah, the one with the ascending pharyngeal branch.
Yeah, I think the ones, these are done with a small amount of onyx or squid or whatever. So you need to have that compatible catheter, and the best catheter that you can use for navigating through these sort of external branches is something 014, which will take an 014 wire. 014 microcatheter. So I think maybe what I used was an echelon 10 or something like that.
Echelon 10,
which is DMSO compatible. Yeah.
All right. So I've not used squid, but is it more in the range of a high viscous onyx or the lower viscous?
No, it is the same. It comes in different sort of viscosities. I think squid also is pretty similar to onyx in terms of I think they name it as squid 10 and 18 or something like that. And the more the number is, the more viscous it is.
Most viscous it is, just like onyx. Okay.
Yeah.
When I trained in my endovascular time, it was all NBCA. Then it has just switched to onyx, and we are using those olive-tipped catheters and to prevent reflux and everything. Now, beautiful that my boss, the mentor who taught me, is Robert Tarr. Robert Tarr is a radiologist, and he was the editor of JNIS. He always used to say, neurosurgeons and neurologists, when you are in doubt, use 10 ml of contrast. So an angiography will solve the problem. So much to say that one of the presentations you probably overlooked was the subdural hematoma presentation of tendoral dural lesions.
Very true.
Because when we have just started a study looking at all the spontaneous subdural hematomas, we do angiograms for them if they are recurrent and if they don't have any blood dysplasias or anything. And in the first 10 cases, we found 3 dural AV fistula.
True.
So, I mean, we selected those cases very carefully. I mean, not one of those herniating ones we do angiograms, but one of those stable ones who did not require surgery. And we observed them for 12 hours. And the PI is Dr. Inam Qureshi, my chair. And we started that. I'm also involved in that. So that is one thing. Second thing is that the subfrontal AVM, the fistula, we would have not done endovascular because it's a straight shot access for a neurosurgeon. And there's no reason why the patient should get all the the access and the radiation and all that. Neurosurgeons would agree to that. And one other thing was that for the cavernous lesion, when all these veins are blocked, we can always use a superior orbital ophthalmic axis. We have done a few cases. There is lots in literature too. That also is one thing to add. But that's one thing. And finally, talking about the nidus of AVMs, we had started a good number of cases with intra-arterial CTA. We access it, park the catheter, move the patient to the CT, and do a CTA run. Our niduses are always bigger than what you calculate on a regular CTA or an MRA. I don't know, Dr. Jayakumar, he has done this, but that is something which you could do and publish. Talking about publishing, there is a coming up RFE for AV malformations, cerebral AV malformations for Journal of Neurosurgery Focus. You should all put your wonderful experiences together. That's all. Thank you very much for your time.
So those are very valid points. Actually, the surgical exposure to superior ophthalmic vein, I've used it several times for this sort of indirect type of CC fistulae, and getting access to the cavernous sinus. So thanks for reminding me that. and the spontaneous subdural hemorrhages as well. I think where we need to have a high index of suspicion. If they are non-traumatic, spontaneous subdural hemorrhages, there is again another condition where you would benefit from a quick angiogram just to exclude anything underlying.
Yeah, and one more thing is that those lesions which abut or go into the brainstem or something, they'll give something for Easwer to do, like like a post embolization resection because of the mass effect and all that.
I'm not sure about these ones. I mean, because they usually kind of such, it's venous ischemia and things like that. I mean, I don't know whether there is any much role in, actual, surgical reduction of that.
No, post embolization though.
Sure, yeah, no, even post embolization. If there's a hematoma, which is sort of big hematoma, of course there is a need for taking that out. I think certainly, yes.
We're talking about zebras anyway, so
yeah.
Yeah, very rare. All right, pleasure talking to you guys.
Thank you so much, Dr. Sunil, for sharing those very invaluable points and spending your very valuable time with us from across the globe. Thank you so much. We also have Professor M.D. Nair sir and Professor Thomas Titus for both a neurologist and cardiologist perspective into this. If they could just share a few comments, please.
No, I just want to know whether the dementia is reversible. If you, in the early stages, if you tackle the dural AV fistulas.
It is, Dr. Thomas.
Dr. Thomas Titus here, sir.
Yes, yeah, hi, Dr. Thomas.
Yes, sir.
The dementia in the early stages certainly is. I mean, I think, there is good results after reducing the flow through the fistulous communications and re-establishing the venous route. I mean, I think this is because of global sort of, venous congestion and a lot of venous edema that affects all parts of the brain. But what we do is we try and reduce the communication as much as possible. And then, as long as things have not been going on for several months or years, there's a good chance that it can be reversed.
Okay, thank you, sir.
Thank you, sir. Professor Thomas Titus is retired head of cardiology from Sri Chitra, and I think sir constantly keeps reminding us that the heart is probably more important or as important as the brain, which we often forget. Thank you very much, sir. MD Nair, sir, your comments, please, sir.
Yeah, it was a wonderful talk. I was really the kind of cases and the different approaches and the way the anatomy was being discussed. So you have to have a good hold of the venous anatomy, and sometimes these dural fistulas can get into a venous thrombosis after some time if they are not attended to. So that is one thing. So many of these patients, they can develop features of venous thrombosis, and we have seen patients with dural fistula also presenting as pseudotumor cerebri and losing their vision because of that. So it is very important.
I'm in a meeting. You tell me anything quick.
Yeah. So these are the things which, as a neurologist, we have to know, and then all the various syndromes, what has been spoken by Dr. Vijay. It was great. And one of the varieties of the dural fistula, they also present as a hemorrhage, spinal hemorrhage. They can present as a spinal hemorrhage. So where the lesion may be just at the base of the posterior fossa. So that one type presents like that. So these are some of the odd presentations, and you have to have a very good angiogram, as was told by Dr. Jayadevan. Unless you do a good angiogram and study the pictures very carefully, you will be missing these. So it was a great presentation. I learned a lot, and traveling with the cases along with you. So remember your very enthusiastic presentations all the time in the Neuroclub, Trivandrum Neuroclub.
Thank you, sir.
Presented. So nice. Very nice.
Thank you.
Thank you very much, sir. I'll just ask a small question from the residents' perspective. A couple of our residents who are a little inhibited about asking it themselves, but they are very much interested in interventional radiology. Many of them, especially both radiology as well as neurosurgery residents who want to take up neuro interventions. they would also like to know that where in the learning curve of an interventional radiologist does dural AV fistulas lie? Is it intermediate difficulty, or on the highest order of difficulty? So at what level of experience would you advise an interventional radiologist to take up dural AV fistulas?
That's a very interesting but a difficult question to answer on the complexity of it. I think by and large we don't. I mean, I think I have to say, when it comes to treating these conditions, I mean, I think it is difficult to take each one separately. Like a dural AVM as a separate entity, then a PL AVM or aneurysm, or things like that. The usual gamut of things that we deal with. I think they all are part and parcel of learning, and that is why we have curriculums and things established. I mean, I think so. It will be very difficult to have a curriculum only for one condition. So you have to have a comprehensive training. And that comprehensive training, the duration, the things that you get exposed to, all those things matter. By and large, once you have finished a certain curriculum which addresses all that, one would be equipped with reasonable knowledge. I think to keep it simple, I mean, I think these conditions are probably they can be very simple to treat, some of them, but at the same time, if you are not realizing the whole kind of abnormal communication and the dangerous anastomosis and things like that, people have burned their hands very badly with some of these, and I've come across several of these over the years, where sometimes it is just a matter of retrospective thinking, but a lot of the time, these are conditions where you can seriously damage somebody in a very big way. So if you, for example, if you have got a vascular artery communication from the occipital, which is not rare, it happens almost in all patients, okay, with this problem. So there are abnormal communications between the occipital artery and the vascular artery, or normal communications which are abnormally large in these sort of situations. And whatever you are injecting, if you don't realize it that it is there, or if you don't anticipate that this is going to happen, you will only realize it after it has hit the basilar artery and the patient is dead. So this is a problem with with this condition, but that's also something that makes it fascinating. All those challenges associated with it. So I cannot put an amount of training into it. I think all neuro-interventional programs should be having a certain curriculum, and that should run for at least an year or two to reach that level of expertise to handle these things.
Thank you so much, sir, for that very, very brilliant and fascinating presentation. We also very personally would like to thank each and every one of our moderators today. Dr. Jayadevan, Dr. Jyothish, Dr. Sunil, Manjila, Professor Easwer, and all in the audience today. I'm sure that there are a few of our residents who still have some questions to ask. The floor is open, and we can keep the discussion going for a short while, because we have an expert with us and you shouldn't miss the opportunity. I'm sure the message has gone out loud and clear, especially for the neurosurgery residents and neurology residents, that when you have a spontaneous intracerebral hematoma, especially which has cortical extent of it, you must think laterally, and before you label it as an idiopathic intracerebral hematoma, think laterally, exhaust all your investigations, and definitely that includes an angiogram, a conventional catheter angiogram, which has to be very painstakingly done, as very nicely illustrated by Vijay Krishnan sir and by Dr. Jayadevan. And the most important aspect is also the atypical presentations of a dural AV fistula. I think Dr. Ajith probably has a question to ask. Ajith sir, please go ahead.
I just ask question if no other residents is there to ask question. Just give them their chance. If no one there, I will ask question.
I think they're inhibited. They have questions, but unless you ask specifically somebody to ask, they wouldn't ask. So they might ask you that tomorrow when you take rounds or something like that. But many of them don't speak up.
Dr. Ajith, you should ask.
I will ask a question just on the resident level, because
sure.
Many a time I have seen so many spinal AVMs not being treated at all. Patient is gradually going for a paraplegia, and usually that ends up in a paraplegia in specialist who doesn't know exact management, and many of them give anticoagulant, and so many things are given without any effect. What is your advice regarding the treatment of spinal AV fistula in that case?
No, spinal AV fistula, it's a, like if you are talking about the dural fistula, the spinal dural AV fistula, that is in the classic sort of spinal dural fistula, which is supplied by usually the branches, the dural branches, which come through the intercostals and the lumbar arteries, and then you have got a dural malformation or a small nidus at the dural level, and then you have got veins which are draining it, which we can see within the spinal canal. So these are, a lot of the time, it depends upon, identifying the abnormality. I think, in all these things, suspecting a patient who is having paraparesis, especially of a chronic, nature, chronic paraparesis with the abnormality on MR, like a wet cord, I think we have to almost always suspect it. In most of these conditions, you can see the flow voids inside the spinal canal on the MR itself. Okay, I've almost never seen a significant fistula or a significant abnormality where there is no telltale sort of engorged veins within the spinal canal. And sometimes giving contrast may help you to get these veins in a little bit more detail. Now, in terms of managing these, I think if it is a standard dural AV fistula which is affecting the spine, because there are a few things. Okay, I think it is not just the standard one, but there can also be the other ones where there is a perimedullary type of fistulae. And also then there is the AVMs, okay, which is a different group of things where there is supply from the anterior spinal artery. So I am talking about purely dural ones where there is no contribution from the anterior or posterior spinal artery, but the arterial supply is predominantly a twig which comes either from the intercostal or the lumbar arteries, and you have got no anterior spinal at the same level. Okay, now these lesions you could address either surgically. I think a lot of the study series show that surgical results are better for dural AV fistulae if because it's a focal area. A lot of the time, identifying it at the time of surgery may be a bit tricky. Now, there are techniques of identifying it, and I've got a paper published where we did a simple intercostal artery marking. Okay, the patient first comes to angiosuit on the same day of surgery. You mark where the intercostal or the lumbar artery, which artery it is, and you can put either a little coil or a little metallic marker at the level. People also can do marking outside the skin on the same day. This can also be done. You do the angiogram and you mark it on the skin using a needle or something, and the surgeon takes the patient, and using the needle, they go and explore that area. A lot of the time, I think surgeons find it difficult to locate this inside once I've opened up. But if you have got something localizing it, either by a small coil in the intercostal or the lumbar artery that is feeding it as close to the pedicle as possible, or a metal marker on the skin, that makes it easier. They can be embolized as well, and I've done several spinal dural fistula embolizations. The key thing is that you should get not only just the area of communication, but also the vein. Whatever you are injecting, especially liquid embolic material, again, most of the time it is histochemical glue, but you have to get the glue to, as in any dural malformation or fistula, you have to get the vein. And a lot of the time, the vein may not be obtained. That is not because somebody is not doing it properly. It is just because of the nature of these things. Okay, and you inject it, and it just keeps starting to reflux along the intercostal or the lumbar artery. It doesn't go forwards. So if it doesn't go forward, you have to stop at some point. Now, those are the patients where you may have to resort to surgery after embolization because their symptoms will recur. They will, of course, improve transiently because you have blocked the flow, but it is not cured. So this is the usual approach to us. I think if a dural malformation, again, although I said surgery, sometimes you have to depend upon how it will work out. See, a lot of this needs very detailed angiography. So spinal angiography takes a long time, and it needs general anesthesia. So if you are, from the imaging, you are suspecting a spinal dural malformation as the very high possibility, I usually consent the patient for embolization at the same time. So when you are doing the diagnostic angiogram, instead of putting the patient through another GA another time, if it is a standard dural fistula where you can got a reasonably good chance of obliterating it endovascularly, just consent him and just do it at the same time. On the other hand, if your angio architecture is different, you have to plan differently, discuss with neurosurgeon, plan, and do it properly.
Thank you.
Okay,
Thank you, sir. Thank you. There was a question from the audience from Dr. Arun Prasad, Lieutenant Colonel Dr. Arun Prasad, who is a final year resident in interventional radiology at Sri Chitra. Dr. Arun asks, what is your anticoagulation protocol after embolization of dural AV fistulas?
None. I think most of the time, none. I think we don't embolize. Sorry, we don't. There is no protocol for giving them anticoagulation. Anticoagulation will be given depending on a case-to-case basis. I think a lot of them, we can do peri-procedural anticoagulation because especially if you are catheterizing the carotid vertebral arteries, etc., which are rare. Most of the time you will be going through the external carotid. So my inclination to anticoagulate even peri-procedurally is quite low these days. But if it is a prolonged procedure, maybe giving some heparin during the procedure, usually it's a 5,000 units bolus during the procedure, and that will take care of it. It is very different to arterial embolization, where you are embolizing an aneurysm or coiling an aneurysm, where you need a lot more meticulous anticoagulation. On the other hand, the post-procedural one in spinal, we do. Okay, spinal, once you have embolized a spinal dural malformation, you usually heparinize them for 24 to 48 hours. The dose is variable. I mean, I think I generally give something like it's people may say that's homeopathic dose, like something like 500 units an hour. More meticulous planning would be to do the ACT, the activated coagulation time, and keep it maybe twice of baseline, which I think is a bit of an overkill for a dural malformation. So I go somewhere in between and give them like 500 units hourly or every 2 hourly. And if the patient starts, very unlikely that they will ooze from the puncture site, etc. If they start oozing, we skip a dose, skip and then do the next hour. For AVMs centered at the cavernous sinus and refluxing into the ophthalmic veins, when you have obliterated them, the patients will usually develop a transient worsening of symptoms. And again, and pain. To reduce those, you can give some anticoagulation. Again, the same dose I use, like 500 units every hourly, 24 to 48 hours.
So you're mentioning about the intra-procedural 5,000 units of heparin. Would that prevent the coil or the material from getting clotted?
No, not at all. No, I think we are packing a space with almost to complete obliteration with that is a that is a preferred result, where you are obliterating the space. It is you cannot partly coil it. So when you are coiling it, you need to obliterate it reasonably, and then the angiograms, you are doing control angiograms during the coiling and also at the end of coiling. So at the control angiogram will tell you whether there is still filling of the fistula or it has completely obliterated. Once it is near complete obliteration or complete obliteration achieved, it's highly unlikely that the anticoagulation will affect it. The anticoagulation only will keep the the normal veins from not thrombosing, etc. And a lot of the time you are going to stop the anticoagulation, if at all. Of course, the procedural anticoagulation, it will stop after the procedure, and the effects are very short-lived. It will everything will go back to normal within a few hours. If you are giving some 24 to 48 hours also, I think as soon as you stop the anticoagulation, the coagulation mechanism will take care of whatever you have done.
We also have another question from Dr. Arun, who asks, what is your experience and views on advanced imaging in dural AV fistulas, that is ASL, SWI, and even TOF MRA?
Yeah, I'm an old-fashioned neuroradiologist who works a lot with this, arteries and veins, and not much of imaging. I do enjoy imaging and do a fair amount of it. But these are, of course, things that Dr. Vijay and Dr. Keshavdas, you should ask in Sri Chitra. I mean, I think we do all these SWIs and all those things. But I think, I think I am a lot more comfortable looking at an angiogram when I have got a catheter in my hand rather than these techniques. They are all very nice, and if you can non-invasively image these things, it will be very nice and very good. But it is a little bit out of my depth, I'm afraid.
I'm sure that Dr. Arun's question is answered. And if anything remains unanswered, Dr. Arun, please, you could probably.
Vijay is doing a lot of work. I mean, I think in Sri Chitra, I think isn't he? I mean, I think he has. I read his papers with a lot of interest, and he will be the ideal person to sort of talk about all these advanced imaging techniques for looking at arteries and veins.
Right. Thank you very much, sir. If there are no more questions, I think on behalf of the Trivandrum Neuroclub, let me very, very profusely thank you for that extremely fascinating talk. Really, it has opened up our minds in various aspects. Thank you so much. I must also thank very profusely Dr. Durga for taking us into those corners of radiotherapy where we were very theoretical in our knowledge, for giving us a lot of practical viewpoints on it. And also let me thank Dr. Ajith, Dr. Jyothish, Dr. Rajeev, who has taken time out from his busy schedule at RCC to share some viewpoints with us. And also would like to thank each and every one of our audience here. People who have worked behind the scenes today to get this meeting going. I must thank Vishnu from Aster, who was the key man to get this meeting organized today. I must also thank Biju from Sun Pharma, who set up this Zoom platform for us, and also Arvind from the technical team, who's working from Delhi to get this recording and all the technical aspects of this correct. I must once again thank each and every one of you for this wonderful evening. And if you want to go back to this evening again and relive it, I'm sure there'll be an opportunity when we put up the YouTube recording of this evening's meeting. So for the residents who had to attend to an emergency call in the ward, or who had to scrub up for a case, we have a time to catch up again with this. We also want to have a small certificate and a token of our gratitude for both our speakers today, which we would probably send it to you across by the online platform, or maybe by email or in some way. And we eagerly look forward to shaking hands with you and meeting you in person at a future date when we have the physical meetings of the Trivandrum Neuroclub in place, which probably, hopefully, if the COVID situation permits, we would be able to start maybe from the month of November. Next. Yes,
George, we can restart the physical meeting, because already many forums have started.
That's right. Yeah, we are seriously thinking about it, but then there are a few who would like to attend the meetings, but who are a little anxious. So they're testing the waters, and we'll give them some more time to test the waters. So hopefully, probably next month or the month after that, we would get started with the physical meetings. But then the glaring advantage of the online meeting is that we could have people from across the Atlantic Ocean also attend these meetings and share their views. So I think
we can make it a hybrid nature.
Probably
physical as well as online meeting can be simultaneously.
We'll surely work on that aspect. The next weekend, we have a joint meeting by the Kerala Neurological Society of India Kerala chapter and the Trivandrum Neuroclub on interesting cases in epilepsy. That will be the next weekend, 9th of November. And I must once again thank each and every one of you for making this evening so memorable. And let me wish you all good night on behalf of the Trivandrum Neuroclub. Thank you very much once again to Jayakrishnan sir, Durga madam, and Dr. Jyothish, Dr. Ajith, and each and everyone, Dr. Jayadevan, and so many who probably were there for even a short time. You made a difference, and your presence kept us inspired. Thank you very much, and good night once again. Thank you.
George, I think it is 9th of October, not November.
Sorry, 9th of October. I think
more keen about neurosurgical meetings than us, because
thank you guys. Good night. Good night.
Good night. Good night, sir.
Good night. Arvind, thank you. We can stop the recording. Thank